Hello, my name is Mary Spisky, and I will be speaking about the Crohn's disease. What is Crohn's disease? So, Crohn's disease is a chronic inflammation that is happening in the GI system. It could happen anywhere from the mouth to the anus. In other words, it can be seen in the ileum or even the colon. But how do we know? What are those symptoms? So the hallmark of the initial symptoms seen on these patients is abdominal pain. Especially they will be complaining of having pain in the lower right abdomen. They will have recurrent diarrheas that might be or not be bloody. They will have flatulence. They will be bloated. They will have abdominal distension. They will have fevers, or they might have periods of being asymptomatic that could be lasting weeks and even months. Other expected finder will be having weight loss due to the recurrent diarrheas, and that will also affect their psychosocial since these patients will be experiencing anxiety and depression. All this emotional or physical stress will often precipitate the flare up of the symptoms. That as they are more frequent, they might also be unrepeated, they might be even more serious and localized. Now I'm gonna be moving into the differential diagnosis. I have listed 5 in which I'm gonna do it according to priority. The first one is the bowel obstruction, and this is the most emergent one. These patients will probably come to the emergency room due to having excruciating abdominal pain. This patient might be having nausea and vomiting, and even some patients will present constipation. At this moment, the clinician might be overlooking the reasons of or the source of the obstruction to later find out that Crohn's disease was actually the cause. Another differential disease is colorectal cancer. Cancer might be found at the later stage. These patients also will be presenting rectal bleeding, anemia, fatigue, and etc. Then we'll have intestinal tuberculosis, and these patients might be also presenting abdominal pain, fever, weight loss, and also night sweats and chills. Then the fourth disease, it will be celiac disease. This is also an autoimmune disease as Crohn's disease is, but in this case, patients are very sensitive to gluten, and they will be presenting abdominal pain again, and will have nausea, diarrheas. And lastly, we have ulcerative colitis. With this disease, patients will also present diarrheas, will be passing blood, will have abdominal pain, but it will be limited to the colon. I suppose Crohn's disease, it will be anywhere in the intestine. Ulcerative colitis will be just limited to affect the colon. Now we're going to be moving on to the pathophysiology and the clinical manifestations. So Crohn's disease is a multifactorial disease. And this is to say that it could be influenced by genetic infections, immune system, by the environment, and even the food choices that we have. It's a chronic inflammation that is usually an excessive immune response that is activated by the innate or the acquired system. Here, we will see intestinal macrophages, we'll see neutrophils, we will see helper T cells that will be promoting pro-inflammatory mediators like tumor necrosis factors or cytokines, and the specific one are IL-12 and the IL-23. Is important to highlight that the T helper 1 and T helper 17 responses are the crucial mediators in the Crohn's disease inflammatory cascade. Going a little deeper, at the microscopically level, the initial lesions start as a focal inflammatory infiltrate around the crest. This is followed by ulcerations of the superficial mucosa. Then later there will be inflammatory cells that invade the deep mucosal layers, and in that process there will be no granulomas being created around through the whole layers on the intestinal wall into the mesentery and the regional lymph nodes. Then we're gonna see neutrophil infiltration into the crypts that form crypt abscesses that will be leading to the destruction of the crypts, and then it will create a colon atrophy. These chronic damages might be also be seen in the small intestine as well. Here will also be ulcerations present around the whole mucosa. Then at the macroscopically, we'll see hyperemia initially and with edema or involving the mucosa. Later we'll see ulcers from over the lymphoid aggregates that are seen as red spots or mucosal depressions, as seen in the picture below. These can become deep, can become serpiginous ulcers, and these could be located transversely or longitudinally over all the inflamed mucosa. This will give the mucosa an appearance of a cobblestone. That's how they're being recognized. These lesions are also often segmental, and they are separated by healthy areas, and are referred to as skip lesions. Now I'm gonna explain a little bit of what ages Crohn's disease affect the most. So when does it start? So normally it will start between ages 15 and 30 years old. Then there will be a second population. There will be women, and that will be ages between 60 and 70 years old. Then there will be most cases beginning before the age of 30. And then between 20 and 30% will be diagnosed at the age of 20. As far as the type of Crohn's disease or what the area affected more, it will be the colonic and the distal area will be diagnosed in older patients, whereas younger patients have predominantly ileal disease. Now, what are the tests that we need to order? So in order to make proper and accurate diagnosis, we need to request lab and diagnostic studies. So for the blood tests, we can request complete blood count and metabolic panel, and this one will reveal if there is anemia due to vitamin B12 or to iron deficiency. With all the diarrheas, there might be electrolyte imbalances. We can also determine that with the blood work. We can see even if the liver enzymes are affecting or the renal, or there is some renal involvement. We can also order a urinalysis, and that will reveal if there is bacteriuria or leukocyturia. Very important to also order the inflammatory markers. We could order the CRP or the ESR. Also, others that are very important and that could be actually help here see how the ongoing inflammation is. We can request the CRP and the NLR. Then following, we can do diagnostic study. We can start by ordering an X-ray. We can do an upper GI series. We can do a CT exam. We can do MRI. We can do ultrasound, and lastly endoscopy or even a colonoscopy. So how do we treat this patient? So we need to understand that treatment of this condition is lifelong with periods of exacerbation and remission. Chronic disease cannot be fully cured, so we need to do appropriate diagnostic and therapeutic procedures in these patients to manage them well. So, but all of this, it will be tailor based on factors like the disease of severity, the location, and the characteristic of the patient. So first, we will have non-pharmacological treatments. Patient in pain, so we can order pain management. They're having a lot of diarrhea, so we can order antidiarrheal medication, and with all these losses, we can also request for vitamins. As far as the pharmacological treatments, we can start them with steroids, and at the same time, we can use anti-inflammatory drugs like mesasalacin. Um, is there is also when complications arises that we can also order antibiotics, which if the patient have sepsis or if we are managing a perianal fistula, we can combine antibiotic with anti-TNF therapy. We can also order immunosuppressants, and those two we can use thiopurine or use methotrexate. And this is used to maintain the patients in remission. We also consider anti-TNF therapy. This is used as and there's examples of this. It could be infliximab or it could be adalimumab. And we can use them alone or with immunomodulators. Most recently, we have emerging treatments, and this could be monoclonal antibodies. Examples are vedolizumab or ustekinumab. Now I'm going to move into the management. So as clinicians, we need to understand that Crohn's disease is very prone to malignancy, so we can do cancer screening more often. We can request a screening colonoscopy every 1 or 3 years. We can do prevention of osteoporosis. These patients are using treatment with steroids, and that will make the patient more susceptible to osteoporosis. So we can request a bone density regularly. We can do also infection prevention. These patients use immunosuppressive therapy, so we can request for vaccinations to help with that. And lastly, there is also surgical options for those that get complicated with abscesses, fistulas, or toxic megacolons, or if there is any perforation. So now I'm gonna speak about the cultural and socio-cultural considerations. So for a long time, Crohn's disease has been a problem that has been concentrated in the white population. Right now, we are seeing more minority groups. Previously, researchers have stated that the way that white population, the African American population, see Crohn's is different. And this is explained by cultural differences, socioeconomic factors, lifestyle, and family support, among others. So this needs to be then a disease that has to be seen and treated differently among these certain populations. The recommendations have been tailored according to all those considerations. Lifestyle as well plays a role. Stress and smoking are risk factors for developing Crohn's. So, and they can even see or make those symptoms even worse. Crohn's disease treatment and education can vary too from community to another, and these factors are consistent with their socioeconomic capabilities and the way that they can have access to good healthcare. In comparison, There are some data suggesting that white and African American people had difference also on the access to seeing a gastroenterologist. There are also gaps in getting those referrals due to those patients being worried or not or the cost of this healthcare. In other communities, language barriers also is another consideration to look at. Not knowing enough about health conditions about the non-English speaking people can also contribute to the differences in getting important information and being treated with Crohn's. So, having a healthy diet according to their culture. Um, Later, I'm going to be explaining a little more on how we do that. Um, Access to healthcare also, and how they are educated, and also the lifestyle considerations of smoking, food choices, and stress needs to be addressed. So now we have prognosis and health outcomes. There is no cure for Crohn's disease. There are remissions, exacerbations. Lifestyle can help manage the disease and prevent complications. There is important to have an interprofessional team approach that can optimize this outcome. Um, and again, there is no cure for this disease, but the lifestyle changes can help manage the disease and prevent complications. Better outcome might depend upon understanding these differences. As clinicians providing assistance with medical transportation, as an example, give reduced prices for prescription drugs or health education. Maybe have them work with a nutritionist who can offer tips about the diets and how ways to eliminate those flare-ups. Um, and even speaking to a psychological counseling or those that have mental health issues as well. And as part of this effort, it's important also to educate the family members, the social networks, and even the other health providers that are around these patients. About the prognosis, Crohn's disease is commonly good. Most people are able to live fully with active life. Although there might be remissions or exacerbations, appropriate medical and surgical therapy help patients to have a reasonable quality of life. With an overall, there is a good prognosis and extremely low risk of fatal outcome. The importance here is the Crohn experiences differ from different peoples and cultural differences and are associated with what type of outcomes they have. Without effective treatment and lifestyle changes, Crohn's disease can lead to several serious health conditions like ulcers, anal fissures, malnutrition, etc. We're almost finishing. I just want to give a little bit of teaching. For the teaching, there will be maybe requesting these patients to undergo to genetic counseling. We can also do treatment to early detect and be any suggestive or symptoms of having Crohn's disease. We can do dietary modifications. We can teach them on the foods to avoid, like having a lot of sugars, avoid high fibers too, high fats, and also all those type of food that will create inflammation, like red meats. And of course, encourage to eat healthy, using a lot of eat vegetables. They take daily omega-3, eat fish, avocado, and drink a lot of water. And lastly, to avoid environmental triggers like cigarette smoke, air pollution, and medications like NSAID. And this is all for this presentation. I hope it responds uh, to all the questions about Crohn's disease. Thank you so much.